Welcome to the Simplified Dentistry podcast. Join us as we discuss clinical, operational, and financial aspects of your practice, help you enjoy life, and dare to simplify dentistry.
Welcome to the Simplified Dentistry podcast. I'm Dr. Mustafa Shakan, along with my co-host, Dr. Richard Offit. We'd like to welcome today's guest, Rachel Wall. Rachel is CEO and founder of Inspired Hygiene, a coaching firm focused on elevating hygiene services, systems, and profits. Inspired Hygiene strives to help dental teams achieve a triple win with healthier patients, empowered, engaged hygienists, and a profitable practice. Thank you for joining us today.
Yeah, thanks for having me.
So tell
Excited
me,
to be here.
so when a doc calls you up, what's he asking you? What's he looking for? Why call Rachel Wall?
Yep. So we've been really fortunate over the last 20 years to develop a really great reputation and platform for really helping practices elevate the systems in the hygiene department, the services that they're offering, and profitability. So they've either heard us on a podcast, they've been referred by their dental financial advisor, dental CPA, referred by maybe a colleague or another consultant, and they know they have some challenges in the hygiene department, or the hygiene department's just not reaching potential, and they want to at least see, how we can help and what we can do to support them in that area.
So let's get even a little more specific. What would you say off the top is the one issue that dentists are facing?
What's the pain point?
Yeah, exactly. What's the pain?
Yeah.
So I would say there are the practice pain points that they see based on data, or just, when they're doing exams, things that they're seeing maybe that are inconsistent between hygienists. And then there are the industry pain points. And there's a couple different layers there. So we'll start with the first thing is what they might see is they just know that they're going in and doing hygiene exams, and they're seeing that patients are bleeding, or the hygienist is telling them that the patients are bleeding, but there's no periodontal therapy being done. They're not referring out. There's just not really anything being done about that. Maybe they were on a podcast or on one of our growth forums, and we talked about, the risk of not documenting properly or diagnosing disease. And they recognize that there's a lack of consistency and clear standards of care in that area, and they know they need to do something about it. It could be right now, a big one is like profitability, right? The hygienist wages have gone up significantly. Sure. For those practices that are in network, reimbursements have gone down. So they're in that crunch point, and they want to see, what can we do? So our first kind of lever that we turn is first looking at, okay, let's look at the service mix. If everything's a pro fee, then there are things that can be done that will benefit the patients, because not every that's not appropriate for every patient. It'll benefit the patients, it'll benefit the practice, and it'll also benefit those hygienists, because if not every patient is appropriate for a pro fee, then I think in 20 years I've seen one practice that I really truly felt was intentionally neglectful. So most team members want to do the right things for patients. There's just not a system within which to do that.
So you think that's the biggest thing is developing a system and a process?
Yeah.
And that, do you see those systems and processes being created by your lead hygienist or your hygiene team? Or, for me, I'm a solo doc, so I have two hygienists. Mm-hmm. Or do you see that having to come from the clinical leader?
So when they work with Inspired Hygiene, we can help start those conversations and facilitate that, but it's a collaborative approach. So really what we're talking about is one of the root causes of these issues that these practice owners are seeing is there's no written clinical standard of care. Mm-hmm. Really in dentistry, there is no defined standard of care that every practice is expected to follow. It's understood.
I hear you, Rachel, on that, but there actually is. There is a standard of care for periodontal health, right?
By the AAP, what is health versus disease?
Yes. And to get a little more granular on that.
But is there an actual process? There's not a book that you can grab off the shelf. This is how you practice.
There are periodontal textbooks which we utilize to set some of our standards by that and the AAP standards. So I would say that yes, the AAP has set out standards. There are periodontal textbooks, and there's a lot of information that creates an understood standard of care. However, based on my experience, there are a vast majority of dental practices and clinical leaders have never seen those documents, right? That the
Sure.
AAP has put out. So we bring those to light. Like, this is what health is versus disease. So what percentage of your patients would fall into one of these categories? So then we help the team create their own level, or we call it standard of care, that's written, that is a written document that is created. It's not you sitting in your office like writing this out and then just handing it to them. It's a collaborative effort based on clinical acceptable authorities, right, that give those standards of care. And then you create that, definition of this is what it means in our practice. So now once that's created and everybody agrees to it and is committed to that, now we have something concrete that we can really compare our patients to when we're doing those diagnostic assessments. So then, patient A comes in and we've been seeing them for 10 years. Every 6 months, maybe we've been seeing them every 3 or 4 months because they always have bleeding. And now we have this defined standard of care and we've recognized, all right, well, Miss Smith actually has active periodontal disease and she has for years, and we need to convert her into the appropriate therapy so we can stop the progression of this disease, or is it time to refer? And so how we coach teams to do that is, first, look back at the documentation, look back at your clinical notes for maybe the last year or two that you've been seeing, Mrs. Smith. Likely there are some hints there where you've planted seeds with that patient. Maybe it's, I notice you're bleeding more. Let's have you come back in more frequently, or you've recommended a Sonicare, or you've done something. You've made some recommendation in the hopes to get a different outcome. And if you're still seeing the same chronic inflammation, then you can say, Mrs. Smith, we've tried this and this. Your body's not responding the way we had hoped. It's time to do something different. So it's not just, hey, we went to this CE and now our policy is when we see 4mm pockets and bleeding, we're like, the patient doesn't want to hear that. It has to be relevant to them, or maybe it's, and I know that you've been having a hard time managing your diabetes. It's time to do something different and really address this inflammation.
Perfect. That sounds great. Let's, Dr. Shakan, I'm not currently in practice. You are. And Rachel, what is it? What's the landscape look like out there for dental hygiene, finding dental hygienists, training dental hygienists? What's that? Where's that going?
Yeah, it's tricky right now. I'd love to hear your take on it too. What's happening in your practice right now?
I mean, I had a hygienist retire, I guess it's been 2.5, almost 3 years ago. Had kids, retired. When we used to have hygienists leave, you'd put a dental post ad out there and you'd get, 80 resumes or whatever.
Wow.
All of a sudden you're getting 2.
Yeah.
Or 3, and then you're finally finding somebody and you'll bring them in. And we had one just didn't work out. It was not a good hygienist, didn't adhere to what we were trying to do. Patients complained. We just got rid of her, brought another one in. Was not great either. And then you kind of get to where you can't even find them. So now it's this void that has been created, and you have so many hygienists that are now using TempMe or Cloud and things like that. So which are basically the Uber of dental hygiene. So you're going in and you're getting fill-in people from that, and you'll have 4, 5, 6, 7 people coming through your office, and sometimes more. And you try to hire them out of that pool and things like that. But that's kind of where it is. You're just not getting resumes.
Well, that really makes it a challenge to do the things that we talked about before, right?
100%.
I mean, if you've got somebody new
can't do anything
every
with
couple
it.
daif what you're hoping for is a body there to treat these people, right?
Correct. And not only can you not do it, if you want somebody to probe and they don't want to probe, they're not going to probe, and they're kind of like, look, I just won't come back. I'll just take you off my list. Yeah.
So I've been telling all my friends that are not in the dental industry, like, if you see a different hygienist every time you go to the dentist, don't assume that your dentist is difficult to work for.
Yeah.
Like, we're kind of going through a crisis right now in the industry. But yeah, so I would say it varies in different regions and areas of the country, but we do hear that. I think some areas don't have, was in a practice not that long ago in a small town in Louisiana, and they don't have enough hygienists in that area for these online staffing apps to really work, right? So it's a little bit different in those areas, but we're in a metropolitan area here in Charlotte, and so that is very common in this area. I would say one of the benefits of that is you do have the opportunity to do an actual working interview. You get to really
Sure.
have an experience with them. So there's some upside there. But that's one of the things that we're seeing with clients and just industry across the board is, some hygienists left in the last few years, maybe retired early. A lot also reduced the number of hours that they are working. So it's not just number of hygienists, it's also, capacity to work or desire to work. There are a lot of opportunities for hygienists that outside of clinical that were not there even 5-10 years ago. So there are things that hygienists are doing, in the dental industry and outside of the dental industry as well. And so it is really forcing business owners and us as well to really look like, okay, how do we get creative with this? Because the bottom line is patients need care.
Yeah.
And you're ultimately responsible for that.
No, that's right. I mean, at what point does it become a public health issue?
I think it's there.
Yeah,
To be honest.
and we as dental professionals need to control that narrative, because if we don't control the narrative, and it is a public health issue, that's going to be taken out of our control. In other words, requirements, training requirements will be reduced. Things are going to be changed. There's going to be a lot more, therapists.
It's already happening.
Looking at what did the ADA come out with the other day? They changed regulations.
So what the ADA passed week before last, we just did a whole growth forum on this last week, was there were a number of resolutions that come before the House of Delegates. There were 3 in particular that were approved. One was to allow internationally trained dentists to be licensed as hygienists. The other was to allow dental students, dental residents that had passed a certain level of clinical competency to be licensed as hygienists. And then the other was to basically remove the ratio of instructors to students in dental hygiene programs. And my interpretation of it was to kind of leave it up to the program to determine that ratio, or at least have it be the same as dental student ratios.
Sure.
And so obviously the ADHA, their job is to, represent their members. They came out with a very strong opposition to those resolutions, to the approval of those resolutions. Based on what I could read, is it's all going to be left up to the states. So the states are going to have to decide how they're going to embrace these resolutions, if at all, and how, dental students, residents, internationally trained dentists, how they're going to require them to go through licensing, requirements. So it might be that they're required to be licensed just the same as a hygienist.
Well, you could see where you have students and residents and internationally trained practitioners coming to fill the void. But kind of the thing that I was looking at in the resolutions is the faculty to student ratio.
Mm-hmm.
It doesn't seem like there is a glut of people trying to be hygienists. Is there an overwhelming demand of people who want to be in dental hygiene programs? So would that solve anything? Actually,
the information that we received, and I'm trying to think of if this was on the CODA website or the ADIA, I think it was CODA, was there are some statistics on that website that they're about 25% of the applicants, I think the number was around 40,000 applicants to dental hygiene programs versus about 10,000 that were being accepted into dental hygiene programs. Now, in the last couple years, there has been an increase there have been a few new programs and some increase in spots in available programs. But there's plenty of people applying.
Okay.
And also the other thing that's a realistic issue is dental hygiene instructors have historically made less than practicing dental hygienists.
Sure.
And now, with the dramatic increase in hygiene pay, that gap is probably even farther apart. So, and there've never been like an overabundance of hygiene instructors. So even if you increase the seats, you still have to have a certain number of instructors to supervise, right?
Sure.
But now if that is removed via CODA, then the schools can make more of an independent judgment, is the way that I interpreted that.
Okay.
Yeah, I mean, I read this what y'all are discussing, and when I read it, I thought about it and saying even if the aggregate number of those three categories aren't going to really move the needle in terms of a public health issue. So I was more speaking to we as in the dental profession need to control perhaps and I'm just saying this. I haven't thought through this
Sure.
terribly. Maybe we need to have different levels of therapists. Just like in dentistry, right?
Sure.
Where there's the
There's a
therapist,
DA1, DA2.
and yes,
yeah.
but there's also the therapist category that's being discussed to be able to expand
Like a
services.
mid-level provider.
Exactly.
Yeah, and that's been
Exactly.
something that look, I'm not super active in the political side of dentistry or dental hygiene. So, but my understanding is that that there has been a push by ADHA and dental hygienists for a mid-level provider, something between a hygienist and a dentist. And what's happening instead right now is it's something between a dental assistant and a hygienist.
Right,
Okay,
yeah.
right, and that I think is the spot where, if it is indeed a public health issue, where that number is going to expand. And you think about the military, right, in
Yep.
corpsmen and how long they're trained to clean teeth, and it's
Couple hours.
a couple of weeks, yeah, a couple of weeks.
And
Yeah,
that's
and
the
then they clean our soldiers, right? So,
Right,
so, so
right.
there's going to be, and they do that because there's a massive number of young guys,
And there's a need.
and there's
Yeah.
a need, right?
Right.
So they solved it. Well, I think that we all the stakeholders in dentistry need to be actively involved in controlling and suggesting outcomes.
Mhm.
Otherwise, it's going to be forced down us,
Mhm.
right? And so people like you, right, Rachel. I mean, you need to be out in front on this because it's in and the dental practitioners and hopefully the ADA would get involved. But in terms of being able to meet this public health need, what are your thoughts there? I mean, is it what do you think? I mean, what are you thinking?
I think that an increased number of dental hygiene schools is needed. I don't know that the ADHA feels the same way. Obviously, again, they're representing their members, and we want to look at the long-term solutions, not just short-term solutions. So the fear is always that then there's an overabundance, but even a reasonable number of expansions here and there would not, in areas that really need it, would be very, very helpful. I think that we're going to need to embrace the idea that we're going to need to work within this model. I think I think that it's appropriate to expand roles in all parties for all parties, and the general number of hygienists, I think, are very nervous and resistant to expanding duties of dental assistants to address scaling and things like that. I get that, but there's a issue. There's a problem.
Well, we looked at points in time when we couldn't find anybody. We were looking at some assisted hygiene
Yeah.
opportunities, and if you have the right hygienist and things
Yes.
like that, and can accomplish that, I can see it work. You have to have the
Yes.
right assistant too, but it is definitely a difference in the delivery of care. At least from a patient perspective, I would think.
Yeah, and we teach that. I mean, we endorse assisted hygiene, and we actually have an assisted hygiene boot camp online program that's coming out in January
great.
in 2025. And we're actually doing a webinar on December 6th about it to just kind of introduce that. So we believe that, and that's different than accelerated hygiene. So
Yeah.
we're not talking about just packing it in, and I've seen that done, and it burns everybody out pretty quickly. But if you think about, like, dentists have been working with assistants
Sure.
forever, and that works well. So if you have that same type of relationship where we're really focused on, everybody working to the top of their license and really delivering great customer care, communicating to the patient, not having that assistant be like a second hand, but really being a part of that delivery team, that care delivery team, it can work very well.
We were on Russell Schaefer's Totally Oral podcast a while back, and he's in Louisiana, and he said basically he doesn't have a hygienist, lost a hygienist, and his co-host doesn't have a hygienist anymore. So what they have done is they've embraced is the biofilm
Guided biofilm therapy.
Guided biofilm therapy. They have embraced that, and they were talking about it. So they use it, and
They're doing the hygiene themselves.
They're doing the hygiene themselves with the guided biofilm therapy. But then they're also saying that there are some practitioners that they're having the assistant do the guided biofilm therapy. So I kind of posted that we'd had this conversation, and it was interesting to see kind of some of the responses. You know, you had a few people coming in there and you're like, well, that can't happen. And they're like, well, and I was like, well, how is it? I was like, they're not scaling, you know? I was like,
well, there is scaling as part of guided biofilm therapy.
but I guess it's essentially from sandblasting though, isn't it?
Well, it's a combination of piezo instrumentation and subgingival air polishing. So it depends on the licensing of the state, but I would think that would be very specific. They would need to be practicing according to the state laws.
Yeah, but on the use of the piezo in particular, I think.
And subgingival air polishing. I mean,
even air polishing.
Yeah.
Okay.
yes, because I mean, in North Carolina, I mean, we're in a really conservative state with regards to this. You know, it's just coronal polishing.
Sure. Yeah.
And I would assume that that's rubber cup polishing, but I don't know I don't believe that includes air polishing. So that would be very specific to state by state.
Let's change this up. Let's change this up a little bit. I'm sure we've solved all the issues with manpower on this conversation, but let's look at this deal. So, and you touched on it before, and I think this is a dilemma when we talk to dentists and that we're seeing. So there's a doc that he's in a bunch of networks. And you mentioned the margin compression, right?
Yes.
The reimbursements are going down.
Yes.
The cost of delivering the service is going up. So you walk into an office, and the office is highly dependent on network reimbursement for their hygiene program. And you walk in there, and you're going to see that their employee costs are high, high compared to the norms and all those sorts of things. So how do you coach that? I mean,
how is hygiene profitable in those situations?
Yeah. Well, how do you coach that doc to say, look, you're in these networks, the reimbursement is X, your cost of delivering the care is about the same. And so how do you leverage that up? Or do you just say, hey, quit the networks? What's your approach?
Yeah. So it's all the above, with regards to adding services, and also, are there any of these networks that are not working for you anymore? So before we're ever in the practice, we do the hygiene analysis, essentially. And if we see that they're having a difficult time getting patients in, so if they're booked out months and months, and they have profitability, I like that term, margin compression, if they have that issue, then that's a first conversation. Like, are there any of these plans that are not serving you anymore, like the lowest paying plans? Now, it's tricky when that lowest paying plan is maybe your military plan or your teacher's plan.
Or the largest plant in your town.
Exactly, right? And so there's a business and sometimes a philosophical, need or desire to, honor that type of thing. But so that always comes into play, whether or not they're willing to do that. But we've seen a lot of our clients make changes in the plans that they're in network with to free up some space in the schedule so that then they can elevate the level of care and provide more services to those patients that they need, that are necessary. So that's the first part of the conversation. And then when we go in there and we see, okay, they've addressed that and they're at the point of participation that they want to be at, then we look at, okay, how do we expand services that are addressing patients' needs and problems? And sometimes those are going to be within accepted and covered services, and sometimes they're not. So it depends on where that practice wants to go. And sometimes they're not addressing periodontal disease at all. So the first thing is, okay, that's the low-hanging fruit, was got to be diagnosing and figuring out what's in this patient's best interest, what do they need. And the other thing that we've really been working a lot with our clients on recently in the last maybe year or two is, because we don't want to create a solution in one part of the practice and create a problem in another. So if we're helping them create this great standard of care, hygienists are presenting treatment, doctors are backing them up, patients are saying yes to periodontal therapy, but yet they're not providing the documentation to get the claims paid, then your insurance coordinator is like
Drowning. They're drowning.
And they're resentful
Right.
because they're like, is this really necessary? Like, we were doing fine before this.
Because you have to have the charting. You have to have all of this.
Yes.
Right. And it all has to be submitted
And it
in
has
a
to be
timely.
super
yeah.
detailed. There
Yeah.
have to be diagnostic radiographs. There has to be a complete periodontal evaluation that's charted, right? Including all of the parts of that: bleeding, pocket depths, recession, everything. And in the vast majority of practices, I would say 90% of the practices that we evaluate, now they are doing a much better job of at least getting like probing depths, but there's no bleeding charted or anything else. And so that's not going to support that claim. So you've got to really look at things from in any practice, but even more so in that type of practice. You have to look at, like, is the documentation there to support this? And then just really kind of taking it slow and helping them like master one thing at a time as far as services go. And then they might say, we have some patients come back that they've had non-surgical therapy and, we want to add an adjunct service, or we need to know when to refer, or, we're looking at how can we help them remineralize, areas, and what are the different services that are available now, and then how do we have those conversations with patients if it's not a covered service.
And are these the keys that you're talking about when you're looking at, how do you keep hygiene profitable?
Yes.
Or is there something else that when you say, okay, well, this is what I want, Dr. Offit, this is what I want you to focus on to have hygiene profitable in your practice?
It absolutely is expanding services beyond prophy and bite wings, because it's very, very, very difficult to do that in a heavy in-network practice with the rate that hygiene wages are at now. If it's just prophy and bite wings, it's very difficult to be profitable. So it is expanding services, but in order to get the hygienist to really embrace that, we have to get to the core of what is in the patient's best interest and what are the solutions to the problems that the patients are showing up for, and having that written standard of care for the practice that we went back to.
The ideal thriving practice. If I want my hygiene to be ideal, if I've been coached by you, if you put it in, obviously you've developed the process, and you
want your hygiene to be inspired.
That's right. You've developed the inspirational standard of care process. What does hygiene look like in my practice when you've got it kind of at a thriving spot?
So the hygienists are, when the patient sits in the chair, they're absolutely connecting and building relationships with that patient, but then they're pretty quickly moving into their overall and oral health conversations. So they're doing a detailed review of the medical history. It's not just a, hey, have there been any changes, yes or no? It's, here are the medications you were taking last time. What was your conversation with your medical doctor the last time you were there? What are your what's changed since you were here last? So, and they're really taking all those clues from the patients and what they see in the documentation to, like, okay, what am I really looking at today, and how is this going to play into my evaluation of what I see orally, right? So then they're doing a thorough oral cancer screening, intra and extra oral. They're doing blood pressure screening. They are potentially, while they're doing that intraoral cancer screening, they're looking at airway. They're seeing if there are any things that are indicated on the patient medical history or in that patient interview that might indicate that there's an airway issue. They're doing an evaluation to see, like, okay, this is the treatment plan that was created by Dr. Shakan the last time the patient was in, or when they were a new patient. What has been completed? What is incomplete? And does that still seem like the most important thing based on what I'm seeing and what the patient is saying to me? And then based on our standards of care, I'm doing, periodontal evaluation at the time frequency or the time interval. But if I see that this one of the things that I feel we really do well is help the hygienist develop critical thinking skills.
Mm-hmm.
So it's not enough to just follow
Be a professional.
Yeah, really think about your job, your role as a healthcare provider. It's not just, well, this patient had their periodontal evaluation completed, 11 months ago. So they're not due for perio charting, but yet they come in and I can clearly see that they're bleeding everywhere.
Sure.
Like I got to stop and say, we've got to figure out what's going on. Or, just really thinking about after they go through non-surgical therapy, like what's next?
Mm-hmm.
Like, did this resolve?
Did that solve it?
Right. Did
Yeah.
this resolve? Is there something in their systemic health that could be affecting the result? Do we need to move to the next level? Like what? Yeah. So really thinking past procedures and really thinking about that patient as an overall. I would say then, those types of things and employing some of the products that we have and technology we have on the market today, helping that hygiene department be a profitable part of the practice, building relationships, building patients that want to refer, and also just being a great, positive, contributing part of the team.
It's interesting. I practiced forever and ever, and as a periodontist, and so I'd be at the grocery store. I'd see a friend or an acquaintance, and they'd go, "Hey, how do I know if I have gum disease?" And I always tell them, I go to your dentist, ask them, "Do I have gum disease?" And it should be yes or no.
Yes.
Yeah.
It shouldn't be,
Yes.
and I said, if you can't get a yes or no answer out of that, then you need to explore it further, right?
Mhm.
And that seems so perfect to then fit into the wheelhouse of what you're talking about, Rachel, with Dr. Chacon and I both just, like clap out really loud on this, is practice at the top of your license.
Sure. Yeah.
I think that's an expression that I had not really heard that. And I think that is something that if we can inspire, I hate to use your word over and over, but if we can encourage.
Thank you.
It's a good word.
Yeah, if we can encourage all of our folks that work with us, all of our colleagues to practice at the top of their license, that it would be the services to our patients would be just overwhelmingly better, right?
Yeah.
I agree.
Yeah.
I agree. And I think there's a lot of opportunity to do that. I mean, there are hygienists and dental assistants now that are being licensed for blood draws, for platelet-rich fibrin and things like that. Like, that's not necessarily in the scope of the dental assistant's license, but it's attainable.
Sure. Yeah.
And
Sure.
talk about practicing at the top.
Sure. I mean, you can go for a 2-week phlebotomy course.
Yeah.
I mean, the lady that takes your blood at the hospital, lady or man, they learned they studied
Yeah.
it for 2 weeks, and now they're
Right.
drawing your blood. So we can all learn those skills, right? And so
And anesthesia that we
Right,
now have in
right,
North Carolina,
right.
like really embracing what are you able to do.
Yeah.
Yes, I agree.
Okay, so
Yeah.
Rachel, for our listeners, they've heard us, go on and on about all these different things. Tomorrow, they're going in the office. They're going in the office tomorrow, and we want their day tomorrow to be better than their day today in the office. What are the takeaways that you can give them right now that they can go to work tomorrow and their practice will be better?
If you're a dentist, a dental leader, communicate with your team. We're talking about hygienists specifically, like schedule some one-on-ones. Have some one-on-ones. Don't wait till the annual review. Just schedule some one-on-ones and say, how are things going? What do you feel like is going really well? Where do you need support to be able to fully, to work at the top of your license? What does that mean to you? And what do you need to feel fully supported in this role? And I think that's a good foundation to lay. And then I would say for the dentists and hygienists, like really evaluate when you're seeing the patients, if you were to ask them that question, if you were to ask yourself that question, does this patient have periodontal disease, yes or no? What is your answer going to be? And if it's like, well, I'm not sure, they have a little bleeding, then that leads you to the next step is create that standard of care in your practice. And we have a worksheet on our website. If you go to inspiredhygiene.com under free resources or resource guide, I think it says, there's a standard of care worksheet. And just look through it and start having some conversations. Like if one hygienist is doing perio charting at this interval and another, like just get on the same page with one thing.
Implement systems.
Yeah.
But even just one tiny thing.
Yeah.
Just go in there and figure out, are we probing?
Right.
I mean, I think that's one of the takeaways for I mean, I see a lot of general dentists, do your hygienist probe. I mean, maybe start there, and they may or may not.
And if they're doing that, the next step is, are they recording the bleeding? Because that's super revealing. It's one thing to take the numbers down, right, in kind of a rote way, but then when we're really looking at, is there active inflammation there? And so it's just one small thing.
Well, thank you very much for joining us today, Rachel. We really
Absolutely.
appreciate having you here. Kind of what a term we use a lot is basically daring to make dentistry simple. What are the things that you can do? Can you go into your office and can you dare to engage your hygienist to add things that they're not doing and do things to practice at the highest level? So, our goal here is to kind of develop a community and to bring people together and give them the resources to simplify their lives, simplify dentistry, and simplify care for their patients. So thank you very much for sharing your insight on hygiene, and
My pleasure.
we look forward to talking to you again soon.
Yeah, I
Rachel,
hope so.
thank you so much. I appreciate it.
Thank you. Thank you for having me.